Hi, good evening.
Wow.
And I see that there are some people joining. So hi, thank you all for popping up and seeing the comments pop up. Um, we'll go ahead and get started, and people can continue to join as we talk here, but I want to make sure that we're not wasting any time and can have a really good conversation with Dr. McQueen. I'm going to start just by really quickly introducing myself, the organization, and Dr. McQueen, and then I will hand it over to you and we can do the Q&A. So if you haven't joined one of these events before, my name is Megan. I am the co-founder and board president of Recurrent Pregnancy Loss Association, which is a patient-led nonprofit organization that is really focused on facilitating science and helping doctors and scientists find causes and treatments for recurrent miscarriage. And we started this live event series in December of last year to be able to kind of ask patient questions to experts in this field, because I know that this can be a really complex, I've had 6 losses. I know that it's a really complex medical journey to go through. So that's why we started these Q&As, and we will continue to do them throughout the rest of this year and hopefully into next. So this event tonight, we're talking to Dr. Dana McQueen about chronic endometritis. And before we start asking questions, I just want to give a brief bio of Dr. McQueen, because I feel doctors are always so humble, so I have to give them their shout outs. So I'm going to just read her bio here, and then I'll hand it over to you. So Dr. McQueen is a reproductive endocrinologist at University of Chicago. She's board certified in OB-GYN. She received a bachelor's degree from University of California at Berkeley, and then a medical degree from University of California, Irvine. She also got a master's in clinical research from University of California, San Diego, so a very California girl. And then she headed to really terrible weather, did her fellowship in reproductive endocrinology at she did her residency at University of Chicago, and then her fellowship at Northwestern School of Medicine, and then also did even a sub-fellowship in recurrent pregnancy loss specifically at University of Illinois. Her research focuses very much on recurrent pregnancy loss, and so she has a particular interest in the relationship between chronic endometritis and recurrent miscarriage, and miscarriage in general. So it's like she's the perfect person to be talking to us tonight about this topic. She's published in multiple journals. She's presented internationally and nationally. She is very much an expert in this field, and I couldn't be more excited to be having this conversation. So with that said, maybe Dr. McQueen, if you could tell us a little bit of the personal side of your story. Why did you pick this field? How did you become interested in this space? Who are you?
Yes. So thank you for that introduction.
Yeah.
So I went to medical school at Irvine. I knew I wanted to do OB-GYN. I knew I wanted to do women's health. And I came to University of Chicago, and my first sort of mentor at University of Chicago was Mary Stevenson, who has done an enormous amount of work in recurrent pregnancy loss. And so immediately got involved in some of her research on RPL, and she really focused her clinic on solely RPL. And so I got to see sort of what that would look like. And then because she became chairman at UIC following her position at University of Chicago, she asked if I wanted to come and be her fellow. So she's had a few fellows. This is the only fellowship in the country that is focused really on RPL.
Yeah.
And it's 1 year, and I worked with her just seeing RPL patients and doing research with her. And it sort of continued my interest in this area. I think it's an area that has really a lack of data and a lack of real meaningful research in it. And so we're limited in terms of what we can do in terms of the workup for RPL and our treatment options. And so I think there's a need for research in this space. And the patient population is really fantastic. I love working with patients who have infertility or recurrent pregnancy loss, because we're able to sort of support them through their journey. And I think they have a really amazing goal of becoming parents. And it's so nice to see that when it's successful and share in that experience. So So I think, I think we have the best job, like to grow families, that's my job.
Yeah.
And so, yeah, I can't really imagine a different specialty, to be honest.
Awesome. Well, thank you. And thank you for choosing to work with patients like us. It's great. So we're talking tonight about chronic endometritis, but I want to start with just some like really basic questions because just to like make sure that we're all talking on the same level, because sometimes it can be really confusing and things sound alike. So remind us, what exactly is the endometrium and why is it important and we should care about it?
Sure. Okay, so the endometrium is the lining of the uterus. So the uterine lining obviously plays a central role in the establishment and maintenance of pregnancy. When you, just for sort of a brief overview, when you recruit an egg each month, a dominant follicle grows. That follicle has little granulosa cells in it. Those cells are making estrogen. The estrogen causes the lining of the uterus to thicken, and it prepares it for implantation of an embryo. And then once you ovulate, your ovary starts making progesterone that stabilizes the lining and makes it hospitable for an embryo to implant and grow and be maintained. And we know that if the progesterone level drops, or if you remove an ovary that's making progesterone, it will inevitably lead to a miscarriage. So this lining and this balance between the progesterone level being made from the ovary and the lining of the uterus and its interaction with the embryo is like sort of the critical point in terms of pregnancy maintenance. So I'm definitely interested in how the endometrium plays a role in miscarriage. I think, we've done a great job at evaluating the embryo and starting to do biopsies of embryos and looking at euploid embryos and knowing that embryos that are normal still have miscarriages. And so what could cause that? Is it something further within the embryo, or is it something more on the endometrial side that's causing these miscarriages?
Yeah, something with the interaction between the embryo and the body. Yep. And so then, okay, so that's the endometrium. What exactly is endometritis? What does that mean exactly?
Right.
Yeah.
So endometritis is an inflammation of the endometrium. That's all it means. Typically, it means that inflammatory cells, like white cells, have infiltrated into the endometrium from the bloodstream and are causing an inflammation. And those cells can release cytokines and inflammatory markers. And we think that creates sort of a hostile uterine environment that would prevent pregnancy or would lead to more likely miscarriages. So endometritis can be a whole spectrum of diseases. It can be, acute endometritis, which I think you maybe ask me about in a minute.
Yeah, you can talk about that too. No, because there's different forms. So go ahead. I mean, yeah, tell us what are the different forms of that?
Yeah. So acute endometritis means that you have an actual infection that's causing probably purulent discharge, that's causing a fever, that's causing uterine tenderness. Acute endometritis sometimes happens after a delivery where you had a prolonged ruptured membranes and you got an infection while you were laboring. And then those patients are treated with IV antibiotics after delivery. It can also occur when someone has a miscarriage, and you've heard this term septic miscarriage, where someone gets it's prolonged for whatever reason, wasn't noted. Normally these happen sort of outside the United States, possibly, or outside of a developed country, and you're getting a really bad infection.
Yeah.
That's an acute endometritis.
Okay.
One other thing that can cause acute endometritis would be pelvic inflammatory disease from an STD, like chlamydia maybe. So those are sort of causes of this acute form.
Okay.
When you look at the acute endometritis pathologically, and you send that biopsy sample to a pathologist, they'll see an infiltration of neutrophils. It's like a specific type of white cell.
Okay.
Chronic endometritis is sort of different. It is not an infection that is causing a fever or discharge. It's really much more of a subtle inflammation.
Okay.
And it's characterized not by neutrophils, but by something called a plasma cell, which is a type of B cell, which is it's also a white cell, but it's just a different kind. So when you look at it under the microscope, you can tell the difference between an acute endometritis or a chronic endometritis.
Okay. Cool.
We do think that this chronic endometritis can persist for a long period of time, though, and sort of possibly be caused by an insult years previous, and maybe there's retained tissue or something, and then you have this chronic sort of subtle inflammation in the lining of the uterus for years, is what we think.
So it sounds, I mean, and so like, and even in listening to that, it's like the acute form, you are probably going to be very symptomatic. Like you're going to probably know that there's something wrong and it's not going to feel
Yes.
right and like be seeking out care. But this chronic form, like you may have it and have absolutely no idea because there's not any symptoms telling you that there's something potentially amiss.
Right. So
Yeah.
some studies have said that about 80% of patients will be asymptomatic.
Okay.
So you may not have any symptoms. Some symptoms that people have described would be like a mild pelvic pain, maybe a mild discharge. But
Okay.
really, I think the majority of cases are going to be asymptomatic, where you walk around, you don't know you have any kind of inflammation in your uterus.
Okay. And then just because I want to make sure that we're like being really clear, because it's, I mean, the words like even sound similar to a non-doctor and to like people out in the public. What exactly, like, is there any relationship or what exactly is the difference between endometritis and endometriosis?
Yeah, that's a really common question.
Yeah.
So endometriosis is actually very different. Endometriosis means that the lining of the uterus, so that endometrial tissue, is actually located somewhere other than the lining of the uterus. Okay. So if you have endometriosis, the lining of the uterus is located like in your ovary, causing a cyst like an endometrioma. It's located in the pelvis. It could be located on the side walls of the abdomen. And what happens is each month when you naturally like grow your lining and shed your lining, you can get bleeding or irritation in the lining of the uterus that's located outside of the uterus. And that can cause chronic pain and scar tissue. But it is very different from endometritis, which is an inflammation actually in that lining of the uterus.
Okay. And is it, I mean, is it possible that one could lead to the other or that a patient could present with both potentially? I don't know.
Definitely someone could have both. I don't think necessarily there would be a relationship between the two, like one causing the other.
Okay.
At least
okay. So I guess like then the question is, if somebody is walking around with this and they're not symptomatic for it, they're not like if they have a chronic form and it, you know, they're not experiencing any symptoms, how would you, like, what would indicate that this is something that you might want to check for? How would somebody be diagnosed with this?
Yeah. So we often do biopsies when someone presents with like sort of abnormal uterine bleeding. So someone might come to the gynecologist and say, oh, I'm having weird intermenstrual bleeding, or I'm having really heavy periods. And so they might get an endometrial biopsy just to evaluate the lining. And so this could show up in something like that. Okay. If someone presents with recurrent pregnancy loss, then I typically will do a biopsy. And we've seen that it's increased prevalence in those patients. We used to do biopsies more in the past for infertility, which now that's kind of gone out of favor and we don't really do biopsies so much for infertility. So we're not picking up necessarily chronic endometritis related to infertility. But certainly it's picked up on just sort of random biopsy specimens. If you're not complaining of any symptoms, you may not have this diagnosed at all. And if you're not having any fever, it's probably not necessarily dangerous for you. But what I do think is that it could be related to miscarriage. And so when patients start having multiple miscarriages, then it sort of warrants an evaluation to see if there's something going on in the lining.
Got it. And so, what you mentioned, like you'd have to take a biopsy. Can you explain a little bit more about that procedure? Like what exactly happens and how it's done, and what is that process like if somebody is going to have that procedure?
Right. So an endometrial biopsy, basically you would come to the office. We do a speculum exam, kind of like a pap smear. Then we put this small catheter. It's a very small straw. It goes into the uterus, and we use a gentle suction to remove just the lining that you would normally shed during your menstrual period. Okay. And then we get the little bit of tissue and we send it off to pathology and they can look at it. It does cause a little bit of cramping. So people usually like to take some Motrin maybe a few hours beforehand. The risks of a biopsy are pretty minimal, but you know, you could experience like pain, bleeding, or even infection just from putting something in the uterus always. Yeah. And so we talk to patients about that risk, obviously. And then you clean the cervix with some betadine beforehand to try to minimize the chance of infection. Okay. You know, it would be really unusual for a biopsy to like injure the uterus or cause scar tissue in the uterus, but we often mention that as like a potential, you know, very rare complication from a biopsy.
So, and then if it's, if it does come back positive, then what's the treatment for it? Like, what do you do if somebody has inflammation that you've identified?
Yeah. So typically the treatment is going to be antibiotics, and that's because we think that there's like an infection or sort of a dysbiosis, a change in the microbiome possibly of the uterus, causing this inflammation.
Okay.
We know that other things can cause this chronic endometritis. So polyps, even IUDs, something in the uterus like a fibroid can cause an inflammation there. And so we see that when women have polyps or fibroids, there is a higher rate of having chronic endometritis. And
Really?
probably,
Yeah.
probably taking out those structures will improve it. And so if you have recurrent miscarriage and you find to have a polyp or a fibroid in there, I think it's reasonable to take it out. One of the interesting things that we found is that chronic endometritis is actually increased in women who have retained pregnancy tissue. And so it's a much higher rate. If we did biopsies on women with retained tissue, we did this by all the women that had a miscarriage and had some retained tissue were undergoing a hysteroscopy to remove that tissue. And we looked at the endometrial lining in the area that didn't have the tissue in it, just like nearby. And we found that there was a much higher rate of endometritis in those patients. So there were plasma cells in there. There were these things called endometrial stromal changes, which is like spindling of the cells that just look a different way than typical endometrial cells. Probably about 60% of the patients with retained tissue had sort of chronic endometritis. The patients with recurrent pregnancy loss, but that didn't have any retained tissue, had about a 30% rate. So we think this like retained tissue is a possible cause. And so if you have a biopsy that's positive, it might be reasonable to sort of look for retained tissue, because that could be like what's going on.
And so talk a little bit more about like, what does that mean? What does it mean if you have retained tissue from a miscarriage? And does that then influence like your recommendation for if somebody is unfortunately experiencing a miscarriage, like does that change how you recommend that they manage that loss?
Yeah. So usually what that means is that, so let's back up, I guess.
Sorry. I asked you a double question.
When someone has a miscarriage and they present to you, there's sort of different options in terms of treatment. So you can do expectant management, which means that you do nothing intervention-wise. We wait and we see if the body naturally passes the pregnancy. And oftentimes it will pass on its own. The majority of times it will pass on its own. You're more likely to pass your pregnancy on your own if you have bleeding when you present. If it's a missed miscarriage where there's no symptoms, maybe it's less likely to pass on its own, but it still might. Especially if someone's on progesterone for like fertility treatments and we stop that progesterone, it might pass pregnancy on their own. The next sort of option is that we do some kind of medical intervention where we give you like misoprostol, which causes uterine cramping, and then the pregnancy can pass that way. And then the third kind of option is that we do an intervention like a surgery, like a DNC, where we evacuate the uterus with some suction. We take the pregnancy tissue out. All three options have sort of a similar success rate. Surprisingly, you'd think that like, oh, surgery would always be the best.
Yeah.
But they're really kind of similar in terms of their outcomes. Patients usually have a clear preference for like, I want to have a surgery, I want this to be done, or I really don't want to have an intervention like a surgery, I'd rather pass this pregnancy on my own. And so I try to like kind of use the patient to guide me on how it should be treated. And there isn't data to say that like doing one intervention or another is going to lead to more chronic endometritis. So I think in terms of
that's
chronic
good
endometritis,
to know.
You can do any option. Retained tissue is probably a little bit more common after passing a pregnancy expectantly. And sometimes you can just give some misoprostol and the rest of the pregnancy would pass. Sometimes we can find just like little bits of a pregnancy tissue, like a little piece of placenta that's stuck there. And so when you do a saline ultrasound following a miscarriage, you can see that there's a little bit of retained tissue there. And those are the patients that I usually recommend doing a hysteroscopy to kind of look to see if we can resect it. You can just do a DNC if you see retained tissue, but I prefer to do a hysteroscopy where we can like directly resect that small area, and ideally avoid doing like a global procedure where you could increase the risk of scar tissue afterwards, because unfortunately, I'm sure you realize that like women with recurrent pregnancy loss have a higher rate of Asherman syndrome where you have scar tissue in your uterus, and so you want to minimize as many interventions as you can. But when we do those procedures with the hysteroscopy, we can see that the area around that retained tissue has this inflammation. And we're calling it chronic endometritis. And it has these like plasma cells there and these stromal changes. And whether or not just taking the tissue out cures it, or if you also need additional antibiotics, we don't know yet.
Got it. So, okay. So you have mentioned a couple things. You've mentioned retained pregnancy tissue, uterine polyps, potentially fibroids. What else do you know that may cause this kind of chronic inflammation?
Yeah. Any kind of structural abnormality could.
Okay.
And then, a history of some kind of inflammation or infection like chlamydia could easily increase your risk of having it. But most women are not going to have any of those things. They're going to present, you won't see any retained tissue, but the biopsy specimen will come back with chronic endometritis.
Got it.
I wonder if those women have a subtle retained tissue there that wasn't noted. And that's why I think that when you get this biopsy back on a patient who has recurrent losses, it's reasonable to do a hysteroscopy to kind of look to see, because sometimes you'll find some very subtle retained tissue, or maybe it came out with the biopsy specimen. Okay. And I think this is one of those questions of like chicken or the egg, like is the miscarriage causing chronic endometritis, or is chronic endometritis causing miscarriages?
Yeah.
And it is a hard sort of question to answer.
Yeah.
They have tried to culture the endometrium of women that have chronic endometritis to see if culturing can like reveal very specific bacteria that are causing it. And unfortunately, we're really getting sort of common bacteria. Okay. E. coli, strep, just sort of bacteria that would normally be in the vagina. Anyway, you're going to get these common bacteria back, and it's not going to be a specific agent that's causing it in every patient.
Yeah. Which I guess in some ways it's like, well, at least it's common and you know how to treat it, which so is like, is the treatment, regardless of sort of what's causing this, the treatment protocol would be the same for.
Right. Similar. So if you see that there's something in the uterus causing that you think could be causing it, then definitely taking that out is one step. And then I typically treat with antibiotics. Most doctors, I think, currently are using doxycycline. So I do a doxycycline 100 milligrams twice daily for 14 days. It's kind of a
it's oral. It's
oral.
Yeah. Okay.
And then I do recommend doing a repeat biopsy. And I usually, and if there's any doctors here, I usually recommend doing that repeat biopsy after their next menses. So you treat them with their first menstrual cycle. You have another menstrual cycle, in my mind, to pass any tissue that might have plasma cells in it, so to avoid a false positive, and then biopsy in the next cycle to see if it's negative.
Got it.
And what's really important is that you have like a good pathologist that you're working with, because the definition of chronic endometritis is highly variable. So when you look at research studies, some studies are going to define it as a single plasma cell in the lining of the uterus on the whole section of tissue that you sent them. And some studies are going to say you need 5 plasma cells in every high power field. And some are going to say 10 plasma cells. And there's just no concrete definition for chronic endometritis that's sort of accepted.
Got it.
I've recently submitted a paper that is under review to try to give a concrete definition that we can all use. And so we'll see if it's accepted. But what we found is that I looked at biopsy specimens from women with recurrent pregnancy loss, and then to controls. And we found that controls do occasionally have these little plasma cells there. Okay. But I don't think that's true chronic endometritis. I think, but what I found in the RPL patients is that they will have plasma cells, but they'll also have these like endometrial stromal changes, which is like spindling of cells, edema of cells. So if you see those stromal changes and plasma cells, that's really the definition, I think, of chronic endometritis. It's like an inflammation of the lining. It looks
and it sounds like an inflammation. Like the cells are not looking normally. Yeah.
Exactly. Whereas if you see like a single plasma cell in an otherwise completely normal lining, we saw that frequently actually in the controls. And these controls were women who were undergoing egg freezing. They had no risk factors for chronic endometritis. I think it's unlikely that they are going to have a true pathology there. So I think defining it as plasma cells plus these stromal changes is going to be like a more meaningful definition. And so we're working, nationally to figure out, can we define it the same way everywhere? And then can we use that same definition to see if chronic endometritis really predicts subsequent pregnancy outcomes?
Got it. So I'm gonna, maybe this is like a tough question, but if there are women that are listening to this that are like, oh, I feel like maybe I should be tested for this, and it's not something that their doctor has recommended, what advice would you give them about maybe initiating this conversation with their doctor, and particularly given your comment about making sure that their doctor is working with a good pathology lab? Like what advice can you give patients?
Yeah. Well, I'll tell you a really short story
Yeah.
about like asking your doctor to do things that are not that they didn't want to do.
Yeah.
I came to my doctor. There was a study called the ARRIVE trial, which showed that if you're induced at 39 weeks pregnant, you have like slightly better outcomes, so lower C-section rates, things like that. So I showed up to my OB appointment like the minute that was published, presented him with my, the abstract because the paper wasn't even out yet. I was like, I'd like to be induced at 39 weeks, and here's the data. So I know I can be the same kind of patient that everyone else is, right? I guess you could bring your doctor a manuscript that shows that chronic endometritis is a higher prevalence in women with recurrent pregnancy loss. We do know that if you compare women with recurrent pregnancy loss and controls, and the study is, going to be out soon, hopefully, that there was a much higher rate of chronic endometritis in the recurrent pregnancy loss group. And so I think it's reasonable to assess for it.
Okay.
What I don't have like real hard evidence on is if you have chronic endometritis, does it mean that you're going to have a miscarriage in your next pregnancy? And
so it's like an association, not causality yet.
Yeah. And your doctor may argue that. They may say, I don't want to do this biopsy. This biopsy puts you at risk because it's an actual procedure and we don't know for sure that it's causing miscarriages. But I think if you have an educated conversation with them and say, listen, there is some data that's associated. I'd like to be tested. I think most doctors would be open to it. Okay. The problem is going to be, what is their pathologist going to do with the sample? So even at University of Chicago, I'm having a discussion with pathologists because they have not typically been doing the same staining that I did at Northwestern. So,
got it.
There's different staining you can do for plasma cells. There's sort of general H&E staining, which just stains the cells in the nucleus. And it can be kind of hard to find the plasma cells in the overall endometrium. And then there's sort of specific staining called CD138, and that can sort of highlight the plasma cells more easily.
Got it.
And not everyone wants to do this special staining. It costs extra money. And what if it picks up cells that, are non-specific staining and we don't want to overdiagnose it? So anyway, each pathologist is going to have a different way. And until we have sort of a uniform diagnosis and a uniform criteria, it's going to be hard to get every pathologist sort of on the same page, I think.
Got it. Okay.
Lots of information. Sorry.
Yeah, no. It's really, but it's helpful information. And I think this is a really, recurrent pregnancy loss is a really complicated experience to be going through. And it does come down to sometimes like really specific things like this. So it is complicated, but like, that's the experience that people are living. So like, we just live in the complex.
Right. And if it comes back positive, which it does in about 30% of patients with RPL, then we treat it with antibiotics. And I would say the majority of time it's gone with the antibiotic treatment if we don't see any obvious retained tissue. So in one study, if you do the doxycycline alone, it's about a 60% cure rate. And so some women will need like a second course of antibiotics. I think it's a little bit higher than that. I think that's probably a low success rate. In another study, they used something stronger, ofloxacin and flagyl, which is sort of a much more strong antibiotic dose. And they had more of like a 90% cure rate. So there are different antibiotics we can use. I usually start with something more simple like doxy, but you can add a different antibiotic to it. And definitely if it's not getting cured with a course of antibiotics, then you want to think about, okay, we need a hysteroscopy. We need to look inside, see what's going on.
Do you see this as something that might eventually get to a point where it's treated like just sort of empirically for RPL patients?
No. Everyone asks that question. Yeah. So if we just give everybody, sort of people say, oh, let's just give everybody doxycycline who has RPL. You could. The main problem, I guess there's several factors. One is we're giving too much antibiotics anyway in the world, right? So we're going to create like antibiotic resistant bacteria if we start treating everybody with antibiotics that doesn't need it. The other downside is that you wouldn't know about the test of cure question. So what if this patient didn't get cured with their antibiotic treatment, and then you wouldn't be able to retreat or do further evaluation. And so at least for research studies, we've always wanted to do a biopsy and then treat and then rebiopsy. And so that's what I've been doing more clinically. Yeah. But it is an interesting question. You could consider it, I guess. Especially if you had a pathologist that wasn't skilled in interpreting the biopsy data. So if you're a doctor that, they're like, I don't think my pathologist is comfortable with this, treating with 2 weeks of doxycycline might be reasonable.
Yeah. And then like, so some, questions that came up for me as a patient, like listening to, so when I listened to your talk about this at ASRM, and like questions that came up for me are things like, do we think that chronic endometritis has any relationship with like endometrial receptivity or endometrial thickness, or like like repeat implantation failure, like all of these things, that other things that we hear about the endometrium, like could some of these things be caused by chronic endometritis?
Yeah, I mean, I think it's a great question. I don't know any data about endometrial thickness, and I really haven't seen much on the ERA and the relationship between like the endometrial receptivity and chronic endometritis. I know the same group that makes the ERA is working on a biopsy that will tell you about chronic endometritis, but we'll also do like a microbiome assessment. And I'm really interested to see how the microbiome is correlated with chronic endometritis. Because there's been some like very preliminary studies that show that if you have a low lactobacillus level in your uterus, so to back up, we used to think the uterus was completely sterile. We used to think, okay, there's no microbiome in there, it's a sterile environment. But more recently, there is like an ultra low amount of bacteria in the uterus, and it's mostly lactobacillus, which is what you have in your vagina anyway, so it's probably like similar flora. And then they found that in women that had like less than a 90% of lactobacillus, so a lower proportion of lactobacillus, those might be the women that have chronic endometritis. So it's sort of a dysbiosis maybe. Anyway, so it's sort of a next step. But yeah, I don't know for sure about endometrial receptivity and the relationship there. It's sort of an interesting next study.
Nice. So and then I guess like, so do you see a history where this is treated empirically? I guess my other question would be like, you're actively studying this. It sounds like, so there's data coming out here, and you're trying to get sort of the standards for doing the pathology of this. Why is this not yet part of the standard RPL workup? Like what needs to happen before this becomes sort of standard treatment for all women, in addition to standard pathology for actually diagnosing this?
Yes. So I think first we do need to have some standard pathology so that we can interpret research studies, because it's really hard to interpret studies when everybody uses a different definition. So I think the first step is to get some standardized definition. And then, like we said, association does not equal causation. So just because we see a higher prevalence of chronic endometritis in women with RPL than what we think we see in sort of the general population. And honestly, this is even actually new data. Like there haven't been a lot of studies before. There are people who don't have any reason to have a biopsy. We just don't have that many control samples. You have to enroll patients to get a biopsy that don't have any symptoms in order to even have a good comparison group. So these studies are just sort of now coming out. And so I think, obviously guidelines lag behind the data a little bit. And our guidelines for RPL came out, I think in 2014 or something. So
I think 2012. It's a while ago.
They're due for a revamp.
I know.
I can't guarantee that
the European ones are more recent, but I don't think they're even different than the US ones. So it doesn't,
I mean, I can't guarantee that chronic endometritis will make it into the diagnostic sort of workup, unless we can show that having chronic endometritis leads to worse pregnancy outcomes. And I have some ideas about how I can do that. So I'm sort of looking into that now. How can we figure this out? But it is hard to recruit patients to a study where you do a biopsy and then say, I'm not going to tell you what your results are, but I'm going to treat half of you with antibiotics and not treat the other half, and then go ahead and have a pregnancy, and we'll see if it's a miscarriage. I mean, it's just a hard study to do.
Totally.
Especially when when I've personally done work in the area and feel like I want to treat it. It's hard even to do as the investigator, right? So,
and the patients are like, what? All it is antibiotics? Please give it to me. I'm fine with that.
Or I'll go to another doctor and get it.
Totally. Okay. So, no, that's really helpful. So potentially maybe this will be standard treatment, but it's very hard to do the studies. And right now there's clear data that there's an association, but lacking the clear causation relationship at this point.
I think this is the hard part about all research in recurrent pregnancy loss, is like these studies are really hard to recruit for. Unfortunately, patients really want an answer, and patients will volunteer to take any medication if you say that it might help. And you have to be really careful about what you recommend, because there's a lot of unsafe medications that can be recommended. And so I think the biopsy is fairly safe. I think treating with antibiotics is pretty benign. And so I'm comfortable incorporating it into my practice. But there's a lot of treatments out there that I don't incorporate in my practice because I just don't feel like there's enough data on those. So,
well, and so I'd love to hear about that. Like, in addition to when you're, you know, I guess a couple questions about that then. Like, do you do this, do you suggest a biopsy for all of your RPL patients, or is it just some of them? And then what other potentially non-standard tests or additional tests are you routinely recommending to your patients that have had recurrent pregnancy loss?
Yeah. So I do a biopsy on all patients with RPL. I think the association is strong enough that it's reasonable to do a biopsy. I want to do a uterine cavity evaluation on everyone, which is recommended. I'm a little quicker to go to a hysteroscopy over just a saline.
Okay.
So I will do salines on some patients, especially if I think it's a really low risk that they have retained tissue. But if someone's had multiple miscarriages, anything over 3 miscarriages, I definitely lean more towards doing a hysteroscopy and really evaluating the cavity. Or if someone's had late losses, like over 10 weeks. In general, I do stick mostly to the ASRM sort of standard workup, unless it's from a research study, because I am worried exactly for that same reason that patients are getting, you know, treatments that are not indicated and that are potentially not safe. One thing I sometimes do is a sperm DNA fragmentation. I don't do it on all patients, but there are cases where I will do a sperm DNA fragmentation. We did a meta-analysis last year, and we looked at all the studies of sperm DNA fragmentation in recurrent pregnancy loss patients, and we compared the mean DNA fragmentation in RPL versus controls, and there was a significantly higher rate of sperm DNA fragmentation in the RPL group. And so I think there is something there. We started a study. I was starting a study with Dr. Latzi at Stanford, trying to recruit men to donate sperm, see if they had DNA fragmentation issues, not tell them the results. This is the same problem we had with chronic endometritis. And then see what would happen in their next pregnancy. This study has been the hardest study to recruit for. I mean, men will not give us their sperm. For whatever reason. Anyway, so we were having, but this, it's an interesting idea. And I think it's something that's going to be studied in the next few years, hopefully. Like, does sperm DNA fragmentation really cause miscarriage, or what's the relationship there? We did do one study recently that looked at paternal aneuploidy rates in men with RPL. And there does seem to be slightly increased paternal aneuploidy. And so you wonder if that's related to the sperm DNA fragmentation, or is there sort of a male factor that really no one's looking at?
No, and it's you know, I feel like that's what's nice is like I'm starting to see at least a little bit of like an increased conversation about that, like, you know, in social media and in like sort of the fertility space. So it's nice to for a lot of reasons, it's nice that is at least starting to be discussed kind of more readily. Yeah,
I mean, the problem with sperm DNA fragmentation is that it's hard to know what to do about it. So
I was going to ask, like, so what do you do with that? Like,
Oh, I see someone asked in the question.
They just asked it right now, but I think I'll let you answer.
So I mean, if you get an elevated sperm DNA fragmentation, you can try, you know, vitamins, you can try all these different interventions, frequent ejaculation. I'm not 100% sure how much those are going to change the sperm fragmentation. I guess if there's a varicocele, you can say remove that. The treatment that's proven to decrease sperm DNA fragmentation is like a testicular sperm extraction, which seems extreme. But, you know, women are going through IVF, so I don't know, maybe it's not that extreme. But so I think there's more. If we're going to say that sperm DNA fragmentation causes miscarriage, then we need to figure out like what we're going to do to treat it. That's sort of the next step.
So, you know, I've asked you a lot of questions kind of like speaking from the patient side. What recommendations or suggestions around chronic endometritis do you have for any doctors that are listening right now or will watch this? Like, what do you recommend to your colleagues about this specifically?
Right. Yeah. So I would say that we have data now that shows that chronic endometritis is associated with miscarriage, associated with recurrent miscarriage. We cannot tell you for sure if it had caused all these miscarriages or if the miscarriages are causing some inflammation in the uterus. I do think it should be treated because it does seem to resolve with antibiotics. I do think it is a true pathology. I think there's been some question of whether, like, if a single plasma cell really means anything, right?
Yeah.
And I think what we've seen with the control data is that maybe a single plasma cell doesn't mean anything, but this plasma cell plus endometrial stromal changes is what's really significant pathology. And the fact that it's cured with antibiotics means that there is a treatment and it does go away. And so I think it's reasonable to evaluate for it and treat it. I recommend doing a biopsy. I don't think it really matters if it's follicular phase or luteal phase. There's been a little data that it might change slightly the prevalence, but I don't think it changes much because I think this chronic endometritis persists throughout multiple menstrual cycles. So it's not like it's coming and going each phase of the cycle. I usually do the biopsy during the follicular phase, which is the first half of the menstrual cycle. So patients will have a period. Typically, they're coming in for a saline ultrasound anyway. Because we're saying, like, let's evaluate your uterus. Let's see if there's any polyps or fibroids, retained tissue. We do that saline ultrasound somewhere between cycle day 5 and 12. And then I do a biopsy at the same time. And then I think being clear with your pathologist about what you're looking for. And so because I just changed sort of institutions, I started to write very specific instructions in my pathology. So it says, like, please evaluate for plasma cells and endometrial stromal changes. And I think once we have more specific diagnostic criteria, then we're going to be able to, distribute that to the pathology teams. And hopefully we can write that diagnostic criteria with the combination and input from pathology.
Yeah, got it. Cool.
So that's my advice. And then my other advice, I guess, would be if your chronic endometritis does not go away with antibiotics, then doing a hysteroscopy to look for retained tissue is probably the next best step. And, I've been contacted by other doctors before. They just email me, say, oh, I have this difficult case. I've treated her twice with these different antibiotics. Is there anything else you can think of? And I'm always happy to get those kinds of emails and think about, like, how we can treat it differently.
Yeah. Well, and that's what I was going to ask is, I'm sure that there are some patients that are, like, listening to this and thinking, I'm not sure if my doctor would, I'm not sure if I can have this conversation with my doctor. So does University of Chicago, do you do consults with other care teams? Do you treat patients that are out of state or in other, like, kind of metro areas that are interested in learning more about this?
Yeah. So we've been doing a ton of telemedicine now that, now because of COVID. So we've kind of set up an infrastructure of telemedicine that I'm not sure if it's really going to go away.
Yeah, that's true.
I would say most of my visits now are telemedicine for the initial consult. And then we do have patients come in for their biopsy and saline. And so if you were from out of state, you could have a consult and we could put in a letter, like we recommend doing an endometrial biopsy, and then your local doctor could do it. If we felt like their pathologist kind of knew what they were looking for, you could come to Chicago if you lived in sort of the nearby area and get a biopsy done. But always happy to see patients by telemedicine. It's pretty easy now. And we're doing it for almost all my news.
Nice. Okay. And I guess, so that was, recommendations to fellow physicians about chronic endometritis. But also, I would say any recommendations about management of RPL in general, since you did the sub-fellowship in this, and since also I do believe that a lot of women are going through, first, second, third miscarriages, probably even more than that, with just a regular OB. So any kind of just general advice for management of recurrent pregnancy loss for the field?
I think the first step when you start to evaluate a patient with RPL is going to be get a really detailed pregnancy history. Try to find out, when did this loss actually happen? So oftentimes patients will report, I had a miscarriage at 12 weeks. But the reality is, like, if you did the ultrasound, the pregnancy measured maybe 6 weeks. And so it's much more common to have these losses that are early, and early losses and late losses are different. And it's pretty unusual to have a combination of both. Most patients will have sort of a similar history in terms of when they had their losses. And sometimes they won't know because, oftentimes general OB is doing their first visit at maybe 10 weeks. And so you won't have had your ultrasound. So patients are having miscarriages before they even see their doctor.
Right.
And so in terms of the care for RPL patients, I would recommend taking a really detailed history. And then, we do most of the things in the ASRM workup. So we're going to check like for diabetes, check prolactin, make sure the thyroid's under control. It's controversial how low the TSH should be when you're trying to get pregnant. We generally try to get the TSH below 2.5, but there's reasonable data that, 4 is reasonable also. There's sort of conflicting data about doing thyroid antibody testing. I typically do it. It's not part of the sort of standard workup, but I don't treat isolated thyroid antibodies. So if there's doctors listening, like if your TSH is normal, but you have thyroid antibodies, I counsel the patient that they may have a higher risk of low thyroid in the future, but not necessarily that we need to treat thyroid antibodies to prevent miscarriage. But there are studies ongoing looking at things like that. I do a cavity evaluation, which means looking at the uterus really carefully. I'm quick to go to hysteroscopy if I need to, if I have any questions about the saline. And then honestly, my recommendation is just follow these patients super, super closely. So, but it also, I would say it does depend on the patient and what they want. So some of my patients will say, I want an ultrasound every week because I need to see that this pregnancy is growing.
Yeah.
And some patients will say, every time I get an ultrasound, it causes a huge amount of stress and anxiety for me. I want to go 2 weeks. If I'm not bleeding, I don't want to look at this every week. And so you have to just sort of like work with the patients and see what they want. But I always go into every ultrasound when it's done. So if a patient has recurrent pregnancy loss, and honestly, for most of my fertility patients too, just because it's the most fun part of my job. But when they come in for their ultrasound for pregnancy, they go in with the scanner. I'm there right when we do when we put the probe in, so I can see if the heartbeat's there and if any abnormalities there. And then I'm able to quickly say, okay, we see this, we see that. We always look at the heartbeat first so we can get that first reassurance. But then I can interpret findings like in real time. I think the hardest part is, or one of the hard parts is going for a scan, not getting a lot of information, and then going home and waiting for someone to call you. Yeah. Even me as a medical student, I had an ultrasound for something so simple as like an ovarian cyst, which at the time, the ultrasound tech wouldn't tell me what she was seeing, and she kept scanning and she kept measuring. And I'm thinking like, oh my gosh, I probably have an ovarian cancer there. What could be there? And, the doctor called me like 4 days later and said, oh, they didn't find anything. Like, how is this possible? I know that she missed something. But my point is that, that is nothing compared to whether or not you're going to be a mom, right? And like whether or not this pregnancy is ongoing. And so if I felt that kind of stress just from measuring a nothing on my ovary, I can't even imagine like going home from an ultrasound and not knowing what's going on. So, so my recommendation for providers or patients is try to have a doctor that's going to be there for you, see you as much as you want to be seen, and like watch you closely during the whole first trimester. I usually do discharge my patients to like their general doctor around 8.5 weeks, 9 weeks. Okay. The risk of miscarriage goes down after 10 weeks to like 2 to 3%. And really it goes back to what it is in the general population. Yeah. If you're having these repeat early miscarriages. So once we can get them back past that 10-week mark, I feel like fairly confident that things are going to go well.
Yeah. And then I guess like sort of last question. So that was a lot of advice for the provider side. What advice generally do you have for, patients that are at all the stages of this journey with trying to overcome multiple miscarriages and grow their families?
I mean, it's just so hard. It is like the most challenging experience. And you have to know that it's not something that you're doing that's causing this. I think that's my biggest, comment. People ask me all the time, what if I change my diet? What if I don't drink out of plastic? And I know that there's data on plastics and things like that, but like, what if I don't, I went for a run and then I had my miscarriage, and I'm sure that I caused it. I had intercourse, and I caused this miscarriage. And to be honest, you are not causing these pregnancy losses. Like the majority of pregnancy losses are chromosomally abnormal. So there is a high likelihood that this is going to be a pregnancy loss no matter what you did. And for the ones that are normal, I mean, I don't think there's anything that you can do specifically outside of like smoking and doing drugs and doing all these things that we know you're not doing to cause this loss. So, trust your body. Let us know when you're feeling something. If you feel different, let us know. We can do an ultrasound. And also, I really recommend that everyone with recurrent pregnancy loss or infertility sees a therapist. it's really hard to go through this, and
Yeah.
everybody needs someone to talk to. And sometimes it's their spouse or their mom or their friend, but sometimes they just need like someone outside of their like world to just let all the information come out. And so I give a referral to like a psychologist that specializes in women's health, pregnancy, fertility, and recurrent pregnancy loss to everybody who comes to see me.
No, I say amen to that. I think, you know, whether it's a therapist, I mean, well, so I saw a therapist for myself, my husband and I saw one for us as a couple. But I mean, if therapy is not your thing, support groups, or but I think, you need a coach, like whomever it is. But I agree with you, really find somebody to talk to, because it's so isolating.
Right. And realize that it's common. It's so much more common than you think it is. So many people have had miscarriages that don't talk about it. You know, as I became more and more in this field, you know, every one of my friends, when they have a miscarriage, will call me, but they're not calling all the other people that they know, you know? And so you realize that almost everyone I know has had a miscarriage, right? So it's common. It's not common to have multiple miscarriages. So it does deserve workup, and it is normal to be upset about it. But it's more common than you think. And it feels isolating, but there's people out there.
Yeah, absolutely. Absolutely. Dr. McQueen, thank you so much. I'm just, we're kind of nearing the end. So a couple things here. First of all, if you do not follow Dr. McQueen on Instagram, you should follow her. So, and I know I saw some good questions coming through. Dr. McQueen is on our advisory board, so I'm sure that if you DM her any additional questions, she probably will answer them. So I'll let you do that offline rather than putting you on the spot. But she's wonderful. Thank you so much for being here. I also want to just do a very mini plug. We're going to be hopefully doing more sessions like this throughout the year. So if there's a particular topic that you're really interested in, that you wish that we could like find an expert to really deep dive into, please send me an email, megan@rplassociation.org, or DM me through Instagram. You can find me on Facebook, however it is. But we want to make sure that we're kind of choosing topics that are really relevant and important to you. And then also, we're an official 501c3 now. So any donations that any donations that you may feel inclined to make are fully tax deductible. And we don't have any staff as this nonprofit. So all the money that you give, we're putting towards trying to be able to fund research and support science and do cool things that help make sure that we can find better answers and better treatments for this, because it's a hard thing to go through. And I fully believe in science. I love doctors, and I know that we can find all the answers. We just maybe need more resources to do it sometimes.
We appreciate you. We appreciate the foundation. Yeah.
Awesome. Cool. Well, thank you so much, Dr. McQueen. Any closing comments? Anything you'd like to add or say?
No,
we got a few more minutes.
The RPL Association, so they can help fund research on recurrent pregnancy loss. That's all my.
And follow us too.
Yes, and follow them. Yes.
Awesome.
All right. Well,
you have a good rest of your evening, and it was this was really lovely. So thank you so much.
All right. Bye.
Bye.